Well, thank you very much, Romulo, and thank you very much for everybody inviting me to give this talk today about the importance of the Raine study, Generation 2 reproductive assessment. This is absolutely crucial that we do this study. Seldom a day goes by without we hearing some catastrophic story about fertility falling off a cliff, sperm counts falling off a cliff, our fertility rate is going. It is fundamental that we do this assessment. On the back of the work by Lou Landau, John Newnham, Fiona Stanley, we have data from before these children were born. They're now turning 33, 34. Our early life predicts our health and predicts reproductive function. Reproductive capacity is an essential marker of our health. Yes, the media reports are right. It's all over the media consistently. The media report what society is interested in. Society is interested in this. Everybody on the street is interested in reproduction. The media love it because they're concerned about our fertility. Our Australians' fertility is the lowest it's ever been. We need 2.1 children to replace our population. Some countries are even worse. Korea, 0.7 children born per woman. Japan, 0.8 children born per woman. So this is a global phenomenon. Also, some would say even more importantly, fertility is a marker of our health. A man that needs assistance by assisted reproduction to help him have a baby will probably live less than his friend who didn't. Erectile dysfunction for a young man is a major marker of cardiovascular risk, heart attack. For women, it's even more diverse. A woman who has polycystic ovarian syndrome who has greater risk of diabetes, heart disease, mental health disorder, obstetric problems, difficulty conceiving, increased risk of miscarriage, cancer. A woman with endometriosis, major impact on her quality of life, her social life, professional life, her domestic life, and also potentially struggling with fertility. A woman with reduced ovarian reserve is heading to an early menopause. An early menopause is associated with high risk of osteoporosis, cardiovascular disease, early onset Alzheimer's. So reproductive capacity is a fundamental measure of health, and it's relatively easy to measure, and it's essential that we do this study. The mean age at first birth in Australia is 31, incrementally increasing. The age that we embark on IVF, if we haven't got pregnant, is 35. The Raine study are 33 years of age. The train is leaving the station. We need to be on it. We need to be doing this study. So we're doing this study without very minimal funding. Obviously, I've spent a lot of my life trying to get money, as you can probably tell, but I'm going to have to keep on doing this until we can adequately fund this study. It is absolutely essential. And more importantly, that's what the Raine cohort want to study. If you ask them, as we did, what are the two most important things that you're interested in? It's mental health and reproduction. That's what we're doing. And if you think about it, they're probably linked. We need to do this study. These are my disclosures. Obviously, I've got skin in the game. I'm a national medical director of a big fertility company, so I need to disclose that. So yeah, as you can see, there's a lot of interest in this. We've done studies led by Martha Hickey when the girls were 15, looking at girls mainly for PCOS, and at 21 years of age, we did a male reproductive assessment. We've over 30 publications with this. There's still more to do there if I had researchers to actually analyze some more data. Whatever we publish, it's like wildfire across the media. I can present something and it's been presented, I'm being interviewed in New York, South America, India. The public are interested in this. The Raine study is the only study that can study this. The data is there before birth due to the expertise of you guys in the room. You've been doing assessments continually. Multiple media, and there's taking a screenshot of me being interviewed on the project. Multiple media interest. The press Love it. So this is a busy chart, but I want you to look at this, and it's scary. So on the left-hand side, this is not Trump taking over the States, but the top chart is the publication in 2017 by Haggy Levine. The second, when he looked at it again across the world in 2022. What he's doing, he's looking at all the data on sperm counts across the world, and you can see that now everywhere in the world has been studied. It's not an Australian phenomenon. It's not a northern, it's a Western phenomenon. It is a international. For Africa and Asia, it's the same. Look at the top left. Even those at the back can probably see a difference. 1973 and 2018. That is the average sperm count in in 1973 and then 2018. You can see it's different. And what's the actual fact? In 1973, the mean sperm count in man was 101 million. It's now 49 million. Every man in this room, their sperm count will be less than their father's. Sperm counts have halved over the last 50 years. It's a catastrophe that's happening. What's the rate of decline? Prior to 2000, it was 1% per year. Since 2000, it's 2% per year. I have been in this business for a while, and we keep revising the WHO acceptance of normal downwards. What other aspect of medicine does the normal range keep falling? You don't say, oh, you're not anemic now, but you would have been 5 years ago if we did your blood test with the same level. We keep revising the normal downwards. We're on the 4th iteration, and we shoot for the 5th, and every time we do it, it's falling. Shane Swan, she's not a sensationalist. She is actually a highly respected reproductive epidemiologist. And what she has shown on the back of this data is that sperm counts are catastrophically falling. Rather comically, she said it's going to reach 0 by 2045. So everybody out there, go and freeze your sperm now before it becomes extinct. I can give you a sort of card which unit to go. No, I'm only joking. But this, obviously, I would hope it's going to plateau out. What the hell's going on? Sperm counts are declining. Testicular cancer's going up. Breast cancer's going up. Prostate cancer's going up. These are environmental, endocrine disrupted causes, conditions. As I said, reproduction is the canary in the mine to our health. When I'm seeing a man, he walks in the room, obviously his mainly job is fertility, I'm guessing his sperm count, and I'm generally quite right. It's a marker of health. Absolutely. As I said, a young man with erectile dysfunction will probably have an increased risk of cardiovascular disease and a heart attack. We've talked about the female risks. One with PCOS, increased risk of, if she gets pregnant, miscarriage, obstetric risk, gestational diabetes, preeclampsia, premature delivery, stillbirth. She's got a greater risk in life of diabetes, heart disease, mental health disorder, cancer. It is absolutely fundamental that we unpack this and we can educate and help society to stop this happening. So there we go. We've not flattened COVID. This is not flattening the curve. This is not COVID. This is fertility rate. Australia is the lowest fertility rate ever. That's wrong now. This is a slide I was asked to give in a month ago, and it's now gone down. Australia's fertility rate is now 1.5 children born per woman. I sent it in a month ago, it's out of date. Look at that chart. In the 60s, it was swinging. We all had 3 children born per woman. Then with the advent of women able to control contraception and potentially the termination of pregnancy, the fertility rate's gone. We've gone right down. You can see there's a bit of a blip in the early 2000s. Somebody thought it was a clever idea to incentivize somebody to give them a few $1,000s to have a baby. That didn't last long, as we all realized it cost a bit more than a few thousand to have a baby. So we've gone down. So we're on an inexorable slide down. It's 1.5 children born per woman. Remember, 2.1 children you need to replace your population. 1 in 20 children are born from IVF. Great, don't worry, go and see Professor Hart, he'll sort me out. That's not the right thing to do. I know I see probably some of the most complicated patients, but it's not the right thing for the patient. It's not the right thing for the baby. It's much more rewarding for everybody, including myself, if she gets pregnant naturally. A child born from IVF treatment, unfortunately, has greater long-term health risks. They have greater risk of disability, congenital malformations, heart disease, potentially later life complications. We need to avoid resorting to IVF. It's not an easy way out, but 1 in 20 women, 1 in 20 babies are being born from that. And a woman of mid-30s onwards, it's 1 in 6 or 7. The Raine study is helping us unpack our causes as to why this is happening. So what am I going to do? What is this assessment I keep talking about? Well, we're undertaking an assessment of ovarian reserve. So I'm just checking the time. Checking ovarian reserve, and that's the egg timer test. Some women magazines talk about it. It's the AMH blood test to where she is on the reproductive continuum, how many eggs she's got in her basket, the reserve of the ovaries. We're also combining that with a detailed pelvic scan. This is looking for signs of endometriosis. It's looking for the reserve of the ovary. Is the uterine development normal? Remember, we've got growth patterns from before they were born. Some of those girls I saw at 15 had a slightly small uterus. There is no world data what that means. But as a fertility expert, that makes me worried that she's at greater risk of poor implantation, miscarriage, premature delivery, and early life problems because the baby is born early. We're going to do a detailed pelvic scan and a whole lot of questionnaires. What would you imagine? Obviously, major impact is menstruation on the woman's life, her quality of life, impact on her professional, domestic, social life, difficulty getting pregnant. Unfortunately, her problems that she may have had to access fertility treatment, risk of miscarriage. A whole load of detailed reproductive questions and some more I'll allude to in a minute. For the men, we're also doing a sexual function questionnaire. As we've said, that is really crucial for the man's health, is his sexual function. Easy, doing a semen analysis and also looking at his hormones, because if he's got a degree of low testosterone, that is putting him on a trajectory of cardiovascular disease and diabetes. The questionnaire is fundamental. As I've said, we're going to do a major assessment of the menstrual dysfunction that a woman may suffer, but also we're doing some other important tests. Her thoughts on fertility. Maybe we've got it all wrong. Women now don't want a family. I think they probably do. But actually, why are we postponing? Forever talking about women are leaving it too long and like you're telling them off. But why are they leaving it longer? There may be very good reasons why they're leaving it longer. Perhaps because childcare is not adequate. Perhaps they feel that my career trajectory is not, I cannot achieve where I want to go because I'm limited by me having to step out of the workplace to have a baby. I perhaps want 3 children, but I know I'm not going to achieve 3 because I have to take that penalty of time off work. We do not support women in the workplace for maternity provision. So it could be societal, cost of living pressures. That is a major issue now. Actually, I can't afford a child. Many women now are having, and men are having to get extra qualifications to embark on their journey. So we're older before you get settled in the workplace. Egg freezing now we talk about a lot. So that's, it's sort of thought about rather rudely. It's women who want to postpone their family till they're older. I saw several women in the late 30s yesterday who want to freeze their eggs. I wish I'd seen them in the early 30s at the time we're doing this assessment, because that's when it's much more productive. There's no Medicare coverage for that. I think that's a very sensible thing that Medicare should be doing, is supporting women to freeze their eggs, to preserve their fertility for the future, to have the family that they want. Somebody's done some modeling on that. It's a little bit out of date, 2016. I marked the PhD, that's why I remember it. How much does it cost the taxpayer for a baby at 32 by IVF? $28,000. That's a lot of money. Rubbish. The average IVF baby becomes a contributor, net contributor to society in the tax system at 28. So actually, $28,000 is not a great, huge investment for the future of our country. What do? I see these women at 42 who want a family. Obviously, it breaks their heart and often my heart as well. How much does it cost the taxpayer for her to have a baby? $250,000. The success rates are substantially less. So what is the right thing to be doing? Perhaps we should be offering egg freezing. So perhaps this study, we're asking our Raine study participants their views on this. That's a sensible thing to consider. Fly in, fly out. We talk about fly in, fly out being an impact on mental health. I strongly believe this. The Fin Review refused to, they've asked me a couple of times, but they don't want to put it out there in case it creates a wave of concern. But I think the reason for mental health concerns is she's down in Manchester ovulating, he's up in the Pilbara feeling really lousy, she's really distressed, she's missed another month. I saw somebody last week, they've been trying for a year and a half. They've not been trying for a year and a half. They've had 3 opportunities in the last 18 months to get pregnant because he's never around at the right time. Also, unfortunately, and I see many doctors as patients, we have no idea about our fertility. We're clueless. We're slightly better than the panda, but not much better. Okay? So we'll talk some data on that. And as I said, men, we're going to do some questionnaires for the men about their sexual function. So yeah, so here we go, okay? This is, again, not flattening the curve with COVID. This is, I want a baby, all right? We want 2 children, in fact, which you would aspire to. Age at the bottom. Or what age do we need to start trying to get pregnant if I want to achieve the chance of 2 children? If you're never going to touch IVF, you need to start at 27 to give you a 90% chance of 2 children. If you would embrace IVF, you need to start at 32. If you want to start at for 3, it's obviously way back. Startling figures. So what have we done in the Raine study already? I've already said we assessed the girls at 15. We've shown that girls at 15 whose mothers smoked or their growth patterns were adverse in utero, their uteruses were smaller, their ovaries were smaller at 15. I predict that's a predictor of infertility, miscarriage, growth restriction, leading to problems to the baby born, increased risk of disability. We're going to follow that up again, obviously. The boys, what have we shown? Huge things. A boy that was exposed to the mother smoking, his sperm count is 30% less at 21. 30%, the p-value on that is huge. 30% less at 21 than if his mother did not smoke. We also measured the cord blood estrogens. If the estrogen level for the maternal blood was higher, the boy had reduced sperm count at 21. The intrauterine environment influencing the testicle. Good news story, as you'd expect. If you have a good growth pattern through childhood into adolescence, testicular function's the best. If you have normal BMI trajectory, it's good, best testicular function. So you're not overweight, you're not underweight. Normal pattern of BMI trajectory. So, potential causes I've already alluded to. In utero exposures, we've actually got, and we've published, phthalates and bisphenol alpha antenatally. Patterns of adiposity, our exposures throughout life, over-the-counter medication, our exposures, exercise, diet through life. We're going to associate that with cardiometabolic and mental health risks. And what's the outcome of this? The translation of this will be education. This is going to go across the world. All the reviews, even despite rejecting me, have said this will lead to international plenary presentations. This will lead to a major media interest. Reject. Bizarre, I don't understand it. But we'll be able to hopefully advocate for changing Medicare as well. So I'd really like to thank the Raine study team, particularly people like Blagitza and Beck, and Di, wherever she is, for sort of helping me on this journey to sort of try to get this going. And really, if anybody knows any philanthropic associations or any grants I haven't applied to, please let me know. If anybody's got Gina Reinhardt's mobile phone number, give it to me. Thank you very much.
So we have time for one question. Can I have a runner with a microphone, please? Anybody brave enough to ask Roger a question? Okay, I'm going to ask you a question. So Roger, you published a study that was looking at the epigenetic differences between children born naturally and children born through IVF, which showed no differences. And yet you've just told us that there might well be cardiovascular differences. Can you explain the difference between those 2 statements?
Yeah. Great question. So epigenetics is the way we influence genes. So there's been a lot of work which shows that potentially children born from IVF are at a greater risk of cardiovascular problems. With this work that we've done jointly with the Raine study, we've shown later it doesn't appear to be that way. But certainly there's lots of early data that actually epigenetics is different, but it seems to correct with time. So there's quite a lot of work done showing that young infants born from IVF do have epigenetic methylation patterns that are different. So absolutely, being grown in a little dish in an IVF laboratory is not ideal. Even people have studied different culture mediums, and the growth of the child is different depending which culture medium the embryo. That's 5 days. That's 5 days of growth. The woman carries it for 9 months. But in 5 days of growth, which culture medium we grow the embryo in, the birth weight of the baby will be different. So absolutely, initially epigenetic changes, but it does seem to correct with time. Great question. Okay.
Thank you, Roger.